When we talk about GISSI-3 trial, we're really talking about a moment in cardiology when clinicians were asking a very practical question. Once a patient survives those first few hours of an acute myocardial infarction, what else can we do early to reduce death and limit ventricular damage? Thrombolysis was already in use, aspirin was already in use, but people were still dying, and many survivors were left with adverse cardiovascular remodeling and moving on to heart failure. And so that was the gap that this study, the GISSI-3 trial, tried to fill. Okay? All right, guys, with that, I'm Dr. Busti, your host on This Is Why, where we take medical knowledge from knowing what to why so that we can meaningfully impact how we practice in healthcare. In this series on landmark clinical trials, we're going to explore practice-changing studies like the GISSI-3 trial within the context of the broader evidence so that we can better understand how and why they apply in real-world practice. However, this isn't meant to be an exhaustive journal club. Instead, our goal is to distill each study to its essentials and place it in the proper context so that we can better understand why we do what we do, okay? And so the question becomes, does starting an ACE inhibitor, and in this case it's lisinopril, does starting an ACE inhibitor like a lisinopril very early after an MI actually help? And is routine nitrate therapy also beneficial? Okay? Now the GISSI-3 trial tested both in a very large, pragmatic way. More than 19,000 patients with suspected acute myocardial infarction were randomized within 24 hours in a 2-by-2 factorial design to receive lisinopril, nitrates, both lisinopril and nitrates, or neither, across 200 coronary care units in Italy. Okay? Now those treatments were given for 6 weeks. So this was no tiny mechanistic trial. Okay? This was a very real world, large scale outcome study for its time. Now think about why that design mattered. Okay? They were not just studying a highly selected heart failure subgroup. They wanted a broad acute myocardial infarction population, although they still did exclude some patients who would most likely crash or not do well on vasodilators or who had very severe heart failure. So this was a pragmatic study, but it wasn't reckless. It was asking what to do in a hemodynamically stable post-MI patient that's in front of you. Okay? So here's the headline results. Okay? Lisinopril worked, but it was modest. The 6-week mortality was 6.3% with lisinopril versus 7.1% without it. So that's about an 11% relative reduction that resulted in a p-value of 0.03. So it was statistically significant. Okay? Now, the combined endpoint of death plus heart failure or developing severe left ventricular dysfunction was also reduced with lisinopril. 15.6% of those patients on lisinopril developed those versus 17% who did not receive an ACE inhibitor. Okay? Now, what about the nitrates? Well, routine nitrate therapy unfortunately did not significantly contribute to an improvement in mortality or the combined endpoint. Now that's important, okay? It's an important and relevant teaching point. GISSI was not about a dramatic miracle trial. The absolute mortality reduction was only 0.8%, which gave us a number needed to treat of about 125 over 6 weeks. Now, let's just pause there. A number needed to treat of 126. That means I have to treat about 125 to 126 patients for 6 weeks on these treatments for one of them to benefit. Okay, is that worth it? That's debatable, right? Everybody's got their own opinion. But in a disease as common and as lethal sometimes as myocardial infarction, a modest absolute benefit in a large population still matters to most. Right? And that's exactly how a lot of cardiovascular practice studies changed things in the 1990s. Not from one enormous effect, but from stacking several modest, real benefits on top of each other. Okay? Now, why does this matter mechanistically? Let's think about that. Now, this trial supported the idea that early ACE inhibition after MI is not just about blood pressure, isn't it, right? It's about interrupting neurohormonal activation, reducing adverse remodeling, and lowering that risk and downstream burden of heart failure that can lead to sudden cardiac death. Now, what about further follow-up data? Well, the 6-month follow-up is also helpful here. So even after treatment was stopped at the 6 weeks, the combined endpoint at 6 months still remained lower in the lisinopril group, 18.1% versus 19.3%. Okay? So that suggests that early biologic effect is still being carried forward. Now let's take this one step further. Who seemed to matter the most in this study? Well, later analysis and expert summaries pointed towards greater benefit in higher risk groups, especially those patients with diabetes, an anterior MI, and those with higher KILLIP classifications. There was a diabetic sub-study that is often most commonly cited because patients with diabetes had a noticeably larger mortality reduction than those in the overall trial population. I mean, doesn't that fit with what we see clinically? The higher the remodeling and higher the risk of heart failure, the more attractive early ACE inhibition becomes. But we also need to be intellectually honest. Okay? One aspect of this study is that it was an open label trial. It was also conducted in the thrombolytic era, not primary PCI era. Okay? Now, if you also think about the background therapy that was different from what we use sometimes today, 72% of patients got thrombolytics, 84% were on aspirin, and only 31% received beta blockers. Okay? Furthermore, there was a few safety concerns, especially with hypotension. Okay? And various summaries also mention, obviously, renal dysfunction concerns, which would be obvious issues with ACE inhibitors, right? So you should not lift the exact absolute effect size from GISSI-3 and assume it applies unchanged to modern revascularized statin-treated MI population. But what changed because of this study? GISSI-3 trial was one of the trials that helped normalize early ACE inhibitor therapy after MI as part of routine medical management, especially in stable patients and especially those at higher risk. It also helped clarify something else. Routine nitrate therapy, unfortunately, after MI is not a mortality strategy. However, they can still help symptoms or ischemia. But GISSI-3 did not support giving them across the board just to improve survival. So how do we use this in today's current clinical practice environment? Well, you may not cite GISSI-3 to say every single modern MI patient must automatically get lisinopril on the basis of this one trial alone. Okay? We use it as part of the historical and evidentiary foundation for what current guidelines still support, right? And that is that the blockade of RAAS, okay, after acute coronary syndrome, particularly in patients with reduced EF, heart failure already, anterior MI, hypertension, or diabetes, assuming that their blood pressure, creatinine, and potassium allow it. Okay, so consider the patient in front of you again. Who is that? Well, it's a stable, post-MI patient, most commonly with anterior infarct, diabetes, or mild left ventricular dysfunction, and an acceptable blood pressure. Okay, GISSI-3 absolutely pushes you towards an ACE inhibitor early unless there's a contraindication. What about a patient who is borderline hypotensive, in evolving shock, or a clear risk of vasodilation? That's not the patient population that made this trial successful. And the real issue is not whether ACE inhibitors are good drugs, but whether the patient at this moment can tolerate the adjustment and modulation of the physiology from ACE inhibitors. And so the practical takeaway is this: GISSI-3 mattered because it showed early ACE inhibition after MI provides real, even if it's modest, mortality and remodeling benefit in stable patients, while routine long-course nitrate therapy does not. Okay? In modern practice, the lesson is not to treat everybody reflexively. It's to recognize that post-MI patient likely to benefit and start RAAS blockade early when hemodynamics and the physiology can support it. And that is this trial in its context, guys. And on This Is Why, okay, our goal on this show is to move beyond what the data shows to understand why it matters, so that we can apply it more effectively in clinical practice. If you'd like a deeper breakdown of that trial, you can download the clinical trial handout outlining the study framework and key outcomes. The link is provided to you in the description of the video on YouTube or our podcast channels. It will lead you to thisiswhy.health, okay, where you can access that for free. Okay? If you've not done so already, please be sure to subscribe, give us a like, share this with others, and keep learning why you do what you do, because that changes everything about how you take care of patients. We'll see you next time.